I hope you find this module on neurodynamics helpful in preparing you for active participation in lab. In this module, you will be provided with some background and introduction to theory, learn of key concepts, be provided with indications for testing, discover how to interpret a positive exam finding, and be exposed to the clinical decision-making behind treatment. The content from this module can be found in your course packet. We will begin with some background information. Neurodynamics is based on the hypothesis that nerves need movement, space, and blood for proper pain-free functioning. This concept or approach to treatment was initially termed neurotension, which only considered the length of the nerve. This approach has evolved to be called neurodynamics, where we consider all the mechanical and physiological properties of that nerve. Mechanical properties of a nerve include its ability to compress, bend, turn, slide, and elongate as our body moves. Physiologic properties concern sensitivity levels and thresholds, as well as circulation, fluid dispersion, and ion flow. Dysfunction of a nerve may occur as a result of direct trauma, including compression and traction, or trauma to the tissue surrounding the nerve, which creates compression of that nerve through swelling or chemical irritation. Mechanical consequences of that trauma includes intraneural adhesions or fibrosis within the nerve sheath and/or extraneural adhesions or fibrosis which is between the nerve and surrounding tissue. Physiological consequences of trauma include increased intraneural edema, poor ion channel activity, and decreased blood flow, creating ischemia. Next, we will move to key concepts. These are very important to consider when evaluating and creating a plan of care for a patient. We will start with the concept of the container. Nerves move through tissues, and the musculoskeletal system exerts stress on nerves as we move. An injury to the container can cause nerve irritation. At the same time, injury to a nerve can create issues at the level of the container, including muscle impairments. The next concept is that of the continuum. The nerve is a continuous structure from head to toe that moves as we move. This continuum concept is also what validates the concept of double crush syndrome. Injury to a nerve at one site can decrease the threshold for injury or irritation remotely. For example, a patient with a history of back pain may present with plantar heel pain, which justifies our need for screening neurodynamics. And finally, the continuum concepts allows for structural differentiation. If a patient is having posterior thigh symptoms, we may consider the hamstring or sciatic nerve as the source. A way to differentiate is to ask the patient to move a body part remote from the hamstring, such as the cervical spine. Moving the cervical spine will change mechanical demands on the nerve, but not the hamstring. If that leads to a change in symptoms, we can more confidently say the symptoms are coming from the nerve versus the muscle. Order of movement is also something to consider. What moves first moves most. This will make more sense as we discuss reasoning behind interventions. Anatomy knowledge is a very important component to evaluation and treatment. If you know your anatomy regarding a nerve's path relative to a joint's axis of rotation, as well as its relation to the musculature, you can confidently test and treat with a neurodynamic approach. I have placed a table in your course packet for you to fill out prior to lab. This will aid in your participation and understanding. A key will be posted after lab. So, what is involved in testing? First, the purpose. Performing a neurodynamic assessment is a way to search for impairments related to a patient's activity limitation or participation restrictions. It is also a way to differentially diagnose a pain source. Generally speaking, we are looking if a nerve can or likes to move. So when should we perform a neurodynamic assessment? Does every patient need a thorough assessment? My advice to you is that these subjective findings should flag your attention. First, the description of pain. Pain along the path of the nerve, pain that changes often, or pain mostly felt during ischemic conditions including sleep, static postures, or even cold temperatures should raise your suspicions. Reported sensory changes, especially if you hear the words dripping, heavy, dead, or electrical, may indicate the need for assessment. You may also be on alert with reported motor changes, such as weakness or fatigue. If patients have sustained injuries around nerves, we should remain suspicious. For example, we may want to assess the dynamics of the peroneal nerve when treating a patient post-lateral ankle sprain. Anecdotally, I move towards the neurodynamic assessment if a patient tells me that they are unable to stretch a tight area or that stretching makes the symptoms worse. I also assess after prolonged periods of immobilization. Once past the subjective piece, here is a list of common musculoskeletal conditions or objective findings that may warrant neurodynamic assessment. Other considerations for assessment include patients who are more in the subacute and chronic phase. Those where you were unable to reproduce symptoms consistently with a standard musculoskeletal evaluation, and if no improvements have been made with standard care. Instances where we want to avoid aggressive assessment includes red flag findings, demyelinating conditions, and inflammatory conditions. We should proceed with caution if symptoms of disc pathology or compartment syndrome are highly irritable. During testing, we need to strive to standardize every component, including setup and positioning. We also need to use purposeful language. Evidence points to a change in findings based on words used. Testing is affected by patients hearing that you are testing for a nerve. Try to move very slowly, adding one movement at a time in order to feel for tissue resistance. And always select sensitizing maneuvers away from the location of symptoms to appropriately structurally differentiate nerve from non-nerve symptoms. Now that you know the general components, what are the specific tests? One is a straight leg raise test, which you have learned in the lumbar content. Can you define a positive finding for a nerve root pathology? How about how a positive finding for a peripheral nerve may look different from the positive finding for a nerve root? To better specify a peripheral nerve, we use sensitizing maneuvers at the level of the ankle. For the peroneal nerve, we will use plantar flexion and inversion. For the tibial nerve, we will use dorsiflexion and eversion. And for the sural nerve, we will use dorsiflexion and inversion. Next is the slump test, which you are also familiar with. Again, how would a nerve root pathology present differently from a peripheral nerve? Remember, you may use the sensitizing maneuvers from the prior slide to differentiate the specific peripheral nerves. One important thing to note is that if your patient is presenting with a flexion intolerance, as well as a straight leg raise indicating a possible acute disc pathology, you may want to omit the slump from your assessment and especially treatment. Moving to the higher nerve roots, we have the prone knee bend. Again, ask yourself what a positive finding looks like in a patient with a nerve root pathology or a patient with a peripheral nerve pathology. What peripheral nerve are we looking at specifically here? Specific to the prone knee bend, what difficulties in differentiating do you find? Due to the inability to be able to structurally differentiate, we can use the sideline femoral slump assessment you see here. Now that you know the tests, how do you interpret your findings? If a patient has low back pain with or without anterior thigh symptoms, with a prone knee bend between 80 to 100, We suspect pathology in the nerve roots higher in the lumbar spine. If a patient has low back pain with or without posterior thigh symptoms reproduced at or below a 60-degree straight leg raise, we suspect pathology in the nerve roots in the lower lumbar spine. Speaking outside of the lumbar spine, we suspect a peripheral nerve involvement if we reproduce their symptoms with sensitizing maneuvers or we see an asymmetry of movement of 10 or more degrees. Now that you are familiar with why to test, how to test, and what the test results mean, we will move on to treatment. First, what is our rationale behind treatment? Our goals behind treatment are to restore normal mechanics and physiology, facilitate movement between neural structures and their container, improve circulation, ion flow, and to decrease sensitivity to mechanical changes, improve pain, resolve impairments, and improve fear of movement. The neurodynamic approach is a very holistic approach in that it includes patient education, including postural and ergonomic training, as well as purposeful patient positioning, manual therapy techniques to the container, as well as neuromobilizations such as sliders and tensioners. A slider is what you see in Figure A, where tension is added to one end while it is released on the other end. A tensioner is what you see in Figure D, where tension in the nerve is being taken up on both ends simultaneously. So when do we typically see neurodynamic techniques used successfully in a plan of care? During acute and irritable states, we are using education and positioning strategies to decrease the mechanical stresses on the nerve. When we see low irritability and more stable symptoms, we can progress to the neuromobilizations discussed before. We may also introduce these techniques if we have not seen improvement after 2 to 3 sessions of standard care. We also reserve these techniques for those who have demonstrated a positive test, meaning it reproduces their symptoms and/or is a related impairment. Some specific examples in the lower quarter include a stable lumbar radiculopathy, hamstring strains, piriformis syndrome, and plantar foot pain. We do not want to perform neuromobilizations on patients who are peripheralizing. On to important factors surrounding clinical decision-making. It is my advice to begin under-treating the patient. Start with remote, non-provoking mobilizations. For example, if the ankle is irritable, apply movement proximally first. In most instances, it is beneficial to treat the container first, then perform a slider technique. We dose these techniques similar to joint mobilizations. I would suggest beginning with 60 seconds of oscillations, then reassessing your patient's status. The best question to ask yourself regarding decision-making is the patient's irritability level. If the patient's symptoms are irritable, the goal is pain relief. Thus, we choose strategic patient positioning to minimize tension and compression, as well as non-provoking sliders. Equate it to grades 1 and 2 mobilizations you have learned that are out of resistance. With non-irritable symptoms, our goal is to decrease mechanical sensitivity and improve mobility. This can be done with sliders grades 3 to 4, and in very small cases, tensioners. We have substantial evidence that a nerve undergoes more excursion of motion with less strain during slider techniques. You may progress treatment by either treating the container, increasing the number of repetitions or oscillations, increasing the length of time spent performing the oscillations, increasing the amplitude and grade of movement, and moving the initial application of movement closer to the involved area. We will end with evidence and summary. From this module, you should have an understanding of who needs assessment, how you can use your anatomy to perform sensitizing maneuvers, and how to use sound reasoning while interpreting tests and selecting treatment interventions. If you have questions regarding these points, please bring them to lab for discussion. And finally, looking at the literature, a recent systematic review has indicated that using neurodynamic interventions benefits patients experiencing nerve-related low back pain, plantar heel pain, and tarsal tunnel. More specific to the patients with nerve-related low back pain, those who have pain distal to the buttock, symptoms longer than 3 months, and a positive slump test were more likely to benefit from neurodynamic interventions. Thank you for reviewing this module. I look forward to applying all of this new knowledge you learned in lab.